Thank you, Malagavan. Thank you, President, for giving me this opportunity. Now, I see a lot of people are, very awake and enlightened by most of the talks. But unfortunately, I have given the sleeping time, because I all feel hungry. Which language you want to learn? I'm a Sinhalese guy, so I'm more competent in speaking Sinhalese. People raise the hand, people who cannot understand Sinhalese? No one. So I'll use the both language, Sinhala and English, so that at least I will not fall asleep. Right? So sudden onset blindness. Now, the other thing is that this time, as I told you, once, have you seen who Benjamin Franklin? Yes, if you look at the dollar note, you can see his face is always there. He is somebody who achieved a very influential man in US, but he never became the president of the country. He, started from a very lower level guy and came into a very most influential guy in the country and father of sometimes called US. So he once has said, one of his quote is, "Tell me and I forget. Teach me and I will remember. And involve me and I will learn." So therefore, this is what I usually practice in when teaching also for medical students. I like to involve everybody so that you will learn it. Right? So I will be asking some questions and tell me. So what do you mean by acute visual loss? Somebody who comes to you, what a pain, I can't see. So where can you get the problems? Right? Where can you get the problems? Either it could be problem in the eye. It could be due to a problem in the eye. But 20 minutes or 30 minutes? Okay. 30 minutes, right. I will try some slide. I have to make some slides for the 30 minutes, then extra here. Right, so it may not be related to eye, systemic problems or malingering or whatever functional causes, either eye or non. What are the problems of the eye? It would be ocular causes include media opacities or retinal problems. When you take the eye, right, these are the places that you can go, patient can come sudden blindness. Where are the places? Either any obstruction of light going into the retina. Where? Cornea, lens, vitreous. Those are the opacity places where you can get the opacities, right? What are the other causes of sudden onset blindness? Beyond that, you get the retinal problems, okay? Retinal problems. And then, even behind that, will the sclera cause? No, I mean, those are very rare things. As far as we are concerned, suddenly, the optic nerve problems. So those are the three places that common things are common. Commonly, these are the places that you get sudden onset visual loss. Either opacities which goes up to the vitreous, or retinal problems, or optic nerve problems. So what are the media opacities? As I told you, cornea, how can you get sudden onset corneal edema? You can get the corneal edema or corneal scarring or corneal ulcer. Those are the corneal problems. Or can a keratoconus patient comes with sudden onset blindness? Hands up the people who says yes, a keratoconus patient comes with sudden onset blurred vision. It usually comes to you because you have been looking after the keratoconus patient, been giving hard contact lenses, so suddenly comes with poor vision. How? Yes. Hydrops, acute hydrops. Acute hydrops. So you can come with, even the keratoconus can come to the sudden onset. Or a patient comes to with high keratitis. So a farmer comes to you with a corneal ulcer. Or a patient can with hyphema. A child comes with hyphema. Very common. What do you think? You know what hyphema is? The blood in the anterior chamber. How can it happen? We'll come to that. Or can a cataract patient comes to you with the sudden onset blindness? Yes or no? You may have seen enough patients. But pain is a white cataract, isn't it? Because what does it mean? Other eye is good. Patient suddenly notice one eye is not having cataract, isn't it? That's very common. Patient comes to, or else he has got posterior capsular cataract, and then it has come to the center. Then you get the vision blurred. So that may be the problem. Okay. Now look at this picture and tell me what you see. And this patient comes and you see under the slit lamp. I'm going to ask questions. At least if you can't, if you're embarrassed if I ask questions, so I can ask people who know. Anyone who wants to tell what are the things, mistakes, make a picture, not the patient. Tell me the features that you see in this. Yes? Mid-dilated pupil, yes. And see, okay, before that, ciliary injection. The whole eye is red. Anything else? Mid-dilated pupil. Actually, the cornea also, this is not very clear, transparent, so there is corneal edema. What is the diagnosis? Patient comes with severe pain, actually. Yes, very good. It's acute angle closure glaucoma. Patient comes with sudden onset, the blurred vision, blindness, or acute visual loss. This is one cause. So when you see the corneal edema, conjunctival hyperemia, pupil mid-dilated and fixed, and iris bowed or Bombay, iris Bombay, kind of iris protruding, and lid also swollen most of the cases. So this is acute angle closure glaucoma. I always remember one patient ended up with doing CT, doing MRI by this neurosurgeon, senior registrar when the LTT bombed the Colombo city. What happens? One lady, I still remember the name, I shouldn't tell, got scared in the middle of the night. When you get scared, your pupil get dilated. Once the pupil get dilated, you develop acute angle closure glaucoma. Start projectile kind of vomiting, admitted to neurosurgical unit, but the young senior registrar thought it is raised intracranial pressure, projectile vomiting, so did all the investigations, and next day morning when the neurosurgeon came, neurologist came and transferred to eye hospital. That's why I remember I was in the eye hospital at that time. So it can end up there, severe pain. So hardly comes to the optometric, but it's possible. Now look at this one. So they get severe ocular pain, frontal headache, blurred vision, and halos around the lights. Lights beluham halos pain, no? And nausea and vomiting. So those are okay. Now look at these two pictures. Palaveni picture එකේ මොකක්ද පේන්නේ? මේකත් මේ patient එනේ රිදෙනවා pain නැහැ එකපාරට pain නැති වුණා පළවෙනි picture. What do you see? Oh, very good. There is a epithelial defect. Typical picture එක මොකද්ද මේ ඊයරා මේ උදේ මේ බබාගේ නැත්තම් මහත්තයාගේ ඇඟිල්ල වැදුනා කියලා කියන්නේ. මේ මහත්තයා මම දන්නේ මොනවට ඇඟිලි ගහනවද කියලා. So මහත්තයාගේ ඇඟිල්ල වැදුනා කියලා තමයි හුඟක් වෙලාවට ladies ලා ඉන්නේ ළමයි එන්නේ වැටුණා නැත්තම් අනිත් අය එන්නේ රණ්ඩුවක් බේරන්න ගිහිල්ලා මේක වැදුනා කියලා. So බැලුවාම actually epithelial defect is very painful. How do you manage? As an optometrist, yes, because there is no infection, but at least start some antibiotic ointment, not steroid, antibiotic ointment. You can put there are controversies, you can put eye patch and send. Not home, but probably refer to an eye unit, it is better always. And look at the second picture. If you say this is keratitis, so corneal ulcer, and you can see hypopion, all the features you should be seen, hypopion, so it's a other cause. Now this is a typical picture. Mugut naha hath hondata tiyena, patient comes and say pain naha ekapart. What are the causes? If it is a child, yes, somebody answered. Trauma, very commonest cause is trauma. Sellan kara kara inokota he vaduna high fever patient mehema tunata pain naha. So this is it an important patient for now? Of course, because this patient is going to have but unless the acute stage, okay, you can have glaucoma, you can get corneal staining. More than that, you can have internal problems for the trauma. So therefore, it is important to look at the fundus. So patient should go to an eye unit. Okay, that's it. Other thing is the no pain, nothing, suddenly bleeding. It's still child. It could be a masquerading syndrome. It could be a malignant blood cancer, leukemia. So you have to be careful in those cases as well. Or else it would be old age. Like my age. So what could be the reason? Maybe on and off pain, but a pain. Neovascularization of iris, maybe vein occlusion, maybe diabetic retinopathy, suddenly can come with this. So those are the common things. So you look at those things, hyphema, you can't miss. The moment you take the patient to the anterior, the slit lamp, you will see, and you have to send the patient because you have to investigate why and then. Cataract also can come as sudden onset. But as I told you, so this patient very likely can come to you, pain because suddenly he actually detect it, otherwise. Okay, we were discussing about the cornea, corneal opacities. We were discussing about the anterior chamber opacities like hyphema, and then we were discussing about the cataract, which all can come to you as sudden onset blindness, but still you can easily diagnose it, but hardly manageable at the optometrist level, and we'll have to refer them because there are underlying causes or surgical interventions needed. Now next is the vitreous. So you can get the vitreous, most of the, only 2 things or 3 things that you can have in the vitreous opacities. What are those? Already we discussed one. What is that? Yes? Blood, yes, very good. Vitreous hemorrhage, diabetes. What is the commonest cause of vitreous hemorrhage in the middle age? Like you guys suddenly develop vitreous hemorrhage, 30s, yes? Okay, hypertension, and more than that, posterior vitreous detachment. Patient put flashes light pain නැති වුණා එකපාරට. Posterior vitreous detachment in after 30, between 30 and 40, very common. When the posterior vitreous is detaching from the optic nerve head, tiny capillaries may break, and even 1 drop is enough to cause the blindness. Immediately the patient see, I got developed flashes, or sometimes may not be flashes, but kindly නිකන් දියාලියක් පේන්න වගේ ගියා. ඊට පස්සේ පේන්නේ නැති වුණා, මකුළු දලක් වගේ පේනුණා, and then I got a shadow, and then finally blind. So that is common typical history of posterior vitreous detachment and bleeding, and management is, if you are pretty sure about that, you can observe. And when you look at the vitreous, if it is not very dense, you will be able to see the posterior Weiss ring, or the kind of a cloud-like thing just in front of the optic disc. Even with the slit lamp 90D, you can easily see. And then the blood discs tend to be more there, and then finally drop down to the lower part of the, or inferior part of the eye. So then you are sure about, then see the periphery if you can, and then if there is no lattice or anything, can be. Why the danger that you have to be very careful in those patients? The typical history may be something else, predisposing to something else. What? Very good, retinal tears, retinal tears. So you can get the retinal tears. Therefore, you cannot take it simple like that. So, but the commonest is that, and then the retinal tears. The other vitreous hemorrhage causes is all vascular occlusions, and then giving rise to neovascularization, or diabetes, proliferative diabetic retinopathy. Okay, now that we all know. What are the other causes that you can get the vitreous opacities? Anyone? Vidya? Anything there on the phone about the vitreous opacities, except the blood? Yes? Is blood? No, hemorrhage. Vitreous hemorrhage, except hemorrhage. You can get, yes, yes? Floaters, yeah, floaters. You see floaters. What are those objects causing floaters? You can get the floaters, as you both correctly said, in uveitis. In uveitis, inflammation, a lot of cells come to the vitreous. You can get posterior uveitis. Sometimes can come as sudden onset blurred vision, and then it may not be redness in the front part, but you can get lot of opacities. And the other common is, you can see lot of opacities and blurred vision in toxoplasma. In toxoplasmosis, what happens? Lot of opacities, and patient comes with blurred vision and no pain, no much redness sometimes. So when the posterior pole toxoplasmosis is activated, you can get that. So those are also things that you have to be in your mind when you just think like vitreous hemorrhage may not be. So you have basically, these are common things. There are a lot more other things which we don't have to be, which we can forget even. So the more important thing is blood in the vitreous can cause a sudden onset blurredness. Uveitis, posterior uveitis can cause, which include even the toxoplasma. So can cause sudden onset blurred vision in the vitreous. Okay, now we have finished the opacities, now up to the vitreous, and then you can cause problems in the retina associated causes, which can cause sudden onset blurred vision. What are those things? By looking at this, you don't have to go for lecture or text, you can see where can it be problems. What are the problems? One is retina itself, isn't it? Now somebody said retinal detachment. If the retina is detached, you go blind immediately, within 1 or 2 days. You can be. So what are the other structures on the retina? You can see here. There are 2 types of blood vessels, artery and vein. Suddenly those can get occluded, and the patient comes to you with sudden onset blurred vision or visual loss. What else? And we categorize this also, and this area a special area, because the macular problems also can cause sudden onset blurred vision. But then the patient will see periphery, but because it is the most important thing for our vision, the central vision, when the central vision is gone, patient come to you with sudden onset blurred vision. At a glance, you may not see anything, but if you carefully see, the macula is upset. We'll go into that. Okay, these are the causes that can cause retinal detachment. Now, look at this picture. Retina is, there are folds on the retina on the lower part and not straight. So, this is a retinal detachment. What are the typical history of this patient? There may be no symptoms at all. Suddenly, when you see this, maybe they are for the blood. But typical the thing that the patient come and tell you, තුනක් කියන්න මට කවුරු හරි මොනවාද ලෙඩ ඇවිල්ලා කියන්නේ ඔප්ටොමෙට්‍රිස් ගාවට. Yes, flashes. Curtain එකක් පල්ලෙහාට ආවගේ flashes, floaters and very good. ඒ තුන තමයි තියෙන්නේ. Nothing else. ඊට පස්සේ පේන්නේ නැති වුණා. Flashes, floaters and loss of vision. ඒක තමයි curtain එකක් වගේ මේ ඒක කියන්නේ හැමතිස්සෙම initially they always tell මේ හැමතිස්සෙම එක පැත්තකින් මුලින් shadow එකක් තිබුණා. මේ හැමතැනම මෙතන තිබුණා ටික ටික වැඩි වුණා. ඒක මෙහෙටයි හැමතැනටම යන්නේ like in floaters. That's a typical history. Dilate කරන්නේ නැතුව දන්නවා මෙයාට retinal detachment එකක් තියෙන්න ඕන. What is important? When you see 100 patients, you should listen to that, right? Whatever you see, and then you have to be careful about that patient. Somebody who comes and tell you, pain නැතුණා එක පාට හිත මෙහෙට කැලි ගොඩාක් පාවුණා ඒ කියන එකට වඩා more important in this patient. So that is why important for you to identify when you are in the clinic checking glasses and giving glasses and sending, those patients should identify and send to the other the relevant place. Now look at this one. What do we see? I am going to put 3-4 slides here, but look at all these slides. The first slide, what do you see? This is not normal, isn't it? And what is this? Hemorrhage. And what is this? Hole. There is a macular hole. So all these 4 slides, you have macular problems. Everybody will come and tell you the same thing. Mada pain naha. Or else in this patient probably will come and tell you, ඇදයි ඔක්කොම නිකන් මුලින්ම මට ඇදට පෙනුණා. මේ টয়ලට් එකේ වාඩිලා ඉන්නකොට අර ටයිල් වල ඉරි දිහා බලන් හිටියම සර් ඒක මට ඇදට පෙනුණා. ඉරි. දැනුත් එහෙමයි. That's what they come and tell you. What to do? This is the truth that the patient comes and tell you. Some people are laughing at me. Anyway, so this one also will say මැද පේන්නේ and this will say මැද මොකුත් පේන්නේ නැහැ. ගහ බැලුවම මෙහෙම චිමිනියක් වගේ මැදින් නැහැ. ලොකු ගහක් දිහා බැලුවම ගහ මෙහෙම මැද නැහැ. අර චිමිනි තියෙන දන්නවනේ චිමිනි කියන එක. So ඒ වගේ තමයි තියෙන තමයි ඇවිල්ලා කියන්නේ. These are the typical words that the patient does. So these are macular diseases that you can easily detect with the ophthalmoscope even without looking. So I mean, there are instances that we have given glasses for these conditions. So we cannot miss this thing. Okay, so macula is area of sharp visual acuity, is small, anomaly can cause profound visual loss. Most common cause is subretinal hemorrhage from neovascularization seen in macular degeneration. The commonest causes are the neovascularization, age-related macular degeneration, the macular problem. So macular hole, as I shown you. Or else, the symptoms will be the sudden loss of vision, wavy lines, as I told you, the lines on the tiles is wavy, or when you look at the lamp post, it is, wavy. And or else, the gray areas, CSR, okay. What can you see on this picture? This patient was sent by Padmasiri. Padmasiri, you know, Kuliyapiti in Padmasiri. So this patient has come and so he sent this patient to me, sudden onset visual loss. On the first picture is this. Patient was asked to go and see a retinal surgeon, not specifically me, but the patient didn't go to anybody, waited for 1 week, and then he came to me. Then I said, hardly anything could be done because of the 1 week, this is blood, isn't it? Pre-retinal hemorrhage. Hardly you can do anything, but I did a YAG. After explaining the patient, there might be a possibility still blood is not clotted, and within hours, so it is disappeared. So what happens actually, it dropped down. So the patient improved vision and avoided surgery. Okay, so we have finished about the retina and the macula. Retinal detachment can cause sudden onset blurred vision, or macular problem can cause sudden onset blurred vision. All the cases beyond optometry management, so we'll have to send them. But it is your duty to diagnose the patient. And look at this patient. What can you say about this? Yes, at least, yes, very good. Okay, cherry red spot, okay. And you can see the, these are kind of a not typical red or pinkish color of the retina, pale color retina whole area. But here is deep red. And look at this one, the similar thing. Right? This is the normal color retina, but this is edematous and pale color. And the optic nerve also not reddish, it is pale. But here on this place is cherry red spot. What happens when what is this? Yeah, this is retinal artery occlusion. So we are going to say about the vessels now. What happens when the retinal artery is occluded? Immediately patient's eye get ischemic. And then the retina become edematous, swollen. And then less blood. And then from the choroid, the retina is swollen and it appears like now edematous retina, whitish. But because the macula is very thin, we can now very nicely see the behind the choroid is more blood. This is the choroid is rich blood supply is there. No? So you can see the choroidal reflex there. So that is why you see the cherry red spots there. And with time, what happens? This become pale and the retina become atrophy and irreversible loss of vision. Vision even if you send immediately helicopter very hard you can do anything. Vision will not gain. That's unfortunate thing. So you can get the central retinal artery occlusion. Typical history is මොනවද කියන්නේ ඇවිල්ලා ලෙඩා. එකපාරට පේන්නේ නැති වුණා. මුකුත් නැහැ. No pain, nothing pain නැති වුණා. No pain. Acute painless loss of vision, usually embolic or thrombotic. But you cannot ignore that patient. Why? Next moment the patient will develop what? Yes, other eye, yes. Anything else? Paralyze. Because it could be coming from the heart, because direct blood vessels, no? It could be coming from the carotid bifurcation or internal carotid artery. So you'll have to investigate and see why it is. Right? Or it would be inflammatory like giant cell arteritis. So you have to immediately investigate the patient to prevent, and no harm starting even aspirin, because at least to prevent the blood clotting. But you have to send. Okay. So there are profound visual loss, and diagnosis is bound typically by looking at the eye. You can make the diagnosis, and this is what happened. And next one is, and branch arterial occlusion also will be looking like that. The patient will come and tell you. I mean, in this case, you can see certain areas of visual field, but still comes with very poor vision because the macula is involved in this case. This is a branch arterial occlusion. Okay, look at what is the other type of vessels that you can get? Veins. Now, how come the veins? Look at this. What do you see in this picture? Compared to the previous picture, you saw very nicely the optic disc, but little pale. Here you can't see even the optic disc. Optic disc is edematous. Margins are not clear. And everywhere you get hemorrhages. And if you see the other picture, you can see cotton wool spots here. And you can see margin at least, or even if you can see the disc here, but the margin is blurred here. And the wavy, the veins, when the tortuous veins. So this is typical features of, yes, central retinal vein occlusion. Make a miss when the miss first case that I saw in the eye hospital. I couldn't diagnose this. So this is central retinal so central retinal vein occlusion. So what happened? Loss of sudden pain, loss of vision, and usually elderly patients, and often become bilateral. And the important thing, not like arterial, but recoverable most cases. I mean, a certain percentage of cases you can get reasonably good vision and sometimes fully recover. Central association, you have to treat hypertension, atherosclerotic vascular diseases, glaucoma, hyperviscosity syndrome like polycythemia. You have to investigate and treat those things. The important thing, even if the patient is ignorant, okay, what will you do? A central retinal vein occlusion comes to you, and patient make a hurry. Then ischemic, you can't get the vision, you are also sure. Now patient says to you, okay, now mata make a tharala in pulan the mahate anit hata not very commonly 10% involved the eye. That we can say, okay, and 10% ne kaman nakili in pulan. Can the patient wait like that? No. Why? Very good. No. Yes, patient develops 100-day glaucoma because of the ischemia. Then vein galan blood circulation, the whole eye becomes ischemic. And then in few days time, maybe 1 or 2 months time, patient comes with severe red eye or painful blind eye because iris is start neovascularization, and you can get neovascular glaucoma, and then you get painful blind eye. So you have to prevent that, not to gain the vision sometimes, at least to prevent that and make patient's life comfortable. You will have to do the laser or anti-VEGF treatment. The treatment are either laser, if it is ischemic, or anti-VEGF treatment. Vascular endothelial growth factor like Avastin or Lucentis you can give and treat up to some extent, but not most of the time. So you, when you examine, the features will be there as I explained to you. Branch vein occlusion also will be something similar to that. Okay, now look at this picture. This patient comes to you. What are the things that you, sudden onset blurred vision on his right eye or left eye? Left eye. What do you think? Now look at this. Disc margin is not clear, but this is margin is very good. This is a swollen disc. Right? And look at this one. This is also, this is normal and this is different. So what do you think? These are features of patient. I have hollow and hollow no kote ridena. Pain ne. When you flash the eye and see, you get afferent pupillary defect. What is the diagnosis? දැන් අපි දැන් කතා කරා vitreous කතා කරා retina කතා කරා ඊට පස්සේ පිටිපස්සේ තියෙන එකනේ මේ මොකද්ද optic nerve. So if patient has got optic neuritis, optic nerve inflammation. Sometimes, now look at this one. This is very well, you can see in this picture, you can, by looking at that, the optic nerve head is swollen. You know that it is in the optic nerve. But look at this one. So what does, but still the same history. What does it mean? Optic nerve not necessarily to inflame the front part. පිටිපස්සත් පුළුවන් retrobulbar optic neuritis. Patient මෙහෙම ඇහැ හොලවනකොට ඇයි හොලවනකොට රිදෙන්නේ? Why ඇහැ උඩ මෙහෙම බලනකොට රිදෙන්නේ? Why the patient is getting pain when the moving the eye? Because the optic nerve is inflamed, edemila, and the meninges around the optic nerve coverings are pain sensitive. Meningitis වලදීත් අපිට ඔළුව රිදෙන්නේ brain එක රිදෙන්නේ නැහැ. brain එකේ කැපුවත් අපිට රිදෙන්නේ නැහැ. But the coverings of the brain, no, coverings of the optic nerve is pain sensitive. When it is inflamed, ඉදිමුනාම හොලවනකොට රිදෙනවා. මෙහෙම බලනකොට optic nerve එක හිලවෙනවා. That is why you get the pain. Understood? So typical features of optic neuritis. One is that vision is very blurred. And when you flash the torch, afferent pupillary defect. Why? We have optic neuritis නම් ෆ්ලෑෂ් කරාම මේක හොඳට වැඩ කරන්නේ නැහැ. මේකට ගහපුවම ටක් ගාලා දෙකම constrict වෙනවා. මේකට ගත්ත ගමන් මේකට dilate වෙනවා. Because the light is not conducting for this disease optic nerve, isn't it? Optic neuritis light එක හොඳට ගෙනියන්නේ නැහැ. ඒකයි පේන්නෙත් නැහැ. Optic afferent pupillary defect එකක් එන්නේ. That is the reason. So optic neuritis, you get the optic nerve edema. The other conditions include in the optic nerve, in addition to optic neuritis, there are other conditions like optic nerve edema, which you call papilledema, or ischemic optic neuropathy, non-arteritic type, and giant cell arteritis. Those are the other features that I'm going to discuss. I have 5 minutes more. Okay, optic neuritis, inflammation of the optic nerve. There are various causes, idiopathic, inflammatory, or malignant, drug-induced, toxins, various causes of inflammation of optic neuritis. Our job is not to exactly to find out as an optometrist at that time, is to find out whether the patient is having optic neuritis. Typical features, sudden onset blurred vision, which is a painful blurred vision, and pain increases with eye movement, and the patient has got afferent pupillary defect. When you look at the fundus, you will see optic disc edema most of the time, and it may not be there as well. So those are the features. So that is optic neuritis. This patient you can get now this is typical optic neuritis, which I explained to you. Treatment, there is controversial. Usually they give IV methylprednisolone and then followed by oral steroid. Now what is this patient? This is different, not optic neuritis. If you look at, there are both discs are swollen. Why do I say discs are swollen? You cannot see that nice round margin in this two-dimensional picture, but if you see with the three-dimensional, with the slit lamp, you will see, it's protruding. So what is this typical? When the both eyes are involved, you call it, very good, papilledema. Papilla කියන්නේ optic nerve head එකට. So you get papilledema. The commonest cause is ray. This is actually reflected pressure from the brain, optic subarachnoid space reflected pressure of this thing, and when this is seen, the vision may be better. Not, I mean, if it is optic neuritis, patient hand movement, in papillary edema, patient can see. 612, 636, maybe like that. The vision is not very bad. So it is another clue for you to diagnose, unless very late papillary edema make a pain of patient. But the blind spot is large if you do a visual field. Blind spot is large. So this is what you call papillary edema. Important, because suddenly you have to send. Patient may be having a brain tumor, maybe benign intracranial hypertension. So you have to send the patient immediately for a neurosurgery or neurological imaging or neurologist, not by the eye surgeon. We just only follow up. So optic edema, okay. Unilateral optic edema, okay. Now this patient comes to you. Now he smokes, obese, middle age, hypertension. Comes to you and say, මෙතනත් ඉන්නවා මෙහෙම කට්ටියනේ හොඳට බොනවා සිගරට් බොනවා එකපාරට පේන්නේ නැති වුණොත් what is the diagnosis? සම්දක මොකද්ද diagnosis? This is non-arteritic anterior ischemic optic neuropathy. Non-arteritic anterior ischemic optic. ඒක වෙන්නේ මොකද්ද? There are various theories. The capillary supply or blood supply to the optic nerve head get cut off, right? Blood supply to the front part of the optic nerve is not, and then die. Usually, only a part of the visual field affected. The altitudinal, we call it altitudinal field effect. When you do the visual field, cover and see the main balloon, මට කියන්න කොයි පැත්තද පේන්නේ කොහොම? ඔය මහත්තයාගේ පල්ලෙහා මෙහි යට පේන්නේ නැහැ කියලා. හරි. පල්ලෙහා ටික පේන්නේ නැහැ කිව්වම පල්ලෙහා ටික පේන්නේ නැහැ කිව්වම you get upset. එහෙම නෙවෙයි. So the patient will say lower visual field is upset. පේන්නේ නැහැ. උඩ ටිකක් පේනවා. So that's called altitudinal field effect. Sometimes patient might have really upper field is blurred, lower is better. Right? So those are typical features of non-arteritic anterior optic neuropathy. Hardly we can do anything, but the patient, if you look at the fundus, you can see the upper part of the optic disc is swollen here, not the whole disc. Optic neuritis, the whole optic nerve is involved. This is, but here only a small area is involved. So this is ischemic optic non-arteritic anterior can issaraha kotas optic nerve එක. Anterior ischemic optic neuropathy, not uncommon. There are a lot of patients. You have to see what you have to do is some people give aspirin and control the blood pressure, stop smoking, and hardly anything that even the eye surgeon can do. So very important to see. Okay. Now this patient, this okay, this is anterior ischemic optic neuropathy. This patient comes to you, pain නැහැ. එකපාරට මොකක්ද දෙන්නේ diagnosis? එකපාරට මහත්ය පේන්නේ මේ දෙපැත්ත බැලුවම නහර තියෙනවා අර blood vessels are tortuous, nicely you can see the blood vessels. හැබැයි අල්ලලා බලපුවම pulse නැහැ. මේ අපේ මෙතන අල්ලුවම you can see the temporal pulse, but this patient pulse is නැහැ. ඇවිදින බෑ මහත්ය, ඇවිදිනකොට කකුල රිදෙනවා. බත් කන්න බෑ, කනකොට මෙහෙ රිදෙනවා. කැකෙක්සි කෙට්ටුයි. It's called jaw claudication, intermittent claudication. නැත්නම් ඇවිදිනකොට කකුල රිදෙනවා, calf. What does it mean? Sorry? Yes. So patient has got vascular arterial disease, which is called giant cell arteritis. Why it is called giant cell? Muscular arteries get involved, inflammation of the middle part of the arterial wall. And giant cell is called, when you see histologically, you can see typical various type of specific type of cells called giant cells. So that is why it's called giant cell artery. They're very important to diagnose. That's why I'm putting this patient. This is also optic nerve disease. Why important? You get this one eye today. Next 24 hours, the other eye can usually get involved. So unless you immediately control the inflammation with steroids, so immediately sending the patient is very important. Otherwise the patient will have like this later on time. The optic nerve is very pale, or sometimes the patient can come as the central retinal artery occlusion. You can diagnose this cherry red spot, same picture which I showed you earlier. Or patient will come with third nerve palsy. Giant cell arteritis can come as any type of this problem, because the blood supply to one part, any part of the eye, it can go. suddenly, and then the patient will get sudden effect. So a true ocular cause, so very important to diagnose. Those are the symptoms which I explained to you. Right? Okay, those are all ocular causes. What is about this patient? This patient has got, one of my patient has got what? Right homonymous hemianopia. So can this happen in the eye? No, make extraocular causes or non-ocular causes for blindness. May patient uttavila kiyane eka paata peenna nathi una kiyala. Samalata ekkai kiyanne. Right? Baluhama thamai you get detected. These are patient avila typically mata sir mata homonymous hemianopia එකක් තියෙනවා right side කියලා කියන්නේ. එතන අපි මේක ඩිටෙක්ට් කරගන්න ඕනේ. හැබැයි මට බොඳ වුණා මහත්තයා මේ එකක් මෙන්න අනිත් හැබල ඒකත් පේන්නේ. දැන් තමයි දන්නේ කියලා. So important to examine and see. These are very common. Optometrists usually send to me the hemianopia. And the cases that I have been diagnosed by my colleagues, my friends. Okay, so this is optic homonymous hemianopia. Cause is non-ocular. I told you there are non-ocular causes for things. These are the causes. Usually painless. Vision loss is in the important. Visual loss usually bilateral. If it is brain, usually bilateral, isn't it? And often there are associated symptoms like numbness, weakness, brain-related things, stroke-related things you will have. Or else the causes include stroke or mass or tumor or bleeding into the brain. Those are the common causes. But other non-ocular things include functional visual loss. Recently, my colleague, professor of pediatric, Colombo, sent a child to me. So patient pain board එක පේන්නෙම නැහැ කියලා කියනවා. Nothing බලපුවාම by lacing patient කියන්නෙත් නැහැ මේ examine external visual acuity 636. සමහර වෙලාවට පේනවා play කරනකොට එම පේනවා. What's the diagnosis? Very difficult to catch that fellow. He's a very smart guy. He doesn't want to go to school. Right? He doesn't. So මම හිමීට අම්මා එහාට යවන්නේ දවල්හපම් පුතා මුකුත් නැති නිසා because I am helpless. I couldn't find anything. පුතා ඉස්කෝලේ යන්න වැඩි කැමති නැහැ. Oh uncle කැමති නැහැ. ඇහැ පේනවනේ වාට බොරුනි කියන්නේ මං කියන්නේ නැහැ. ඔය ටිකක් පේනවා කිව්වා. So very important malingering cases you have to so I wrote everything to Sham, my colleague, and sent, and finally now they are managing, so patient is counseled. So those are very important things in diagnosis. So I explain everything. I'm going to finish. I explained you sudden onset visual loss. You have two groups, ocular, non-ocular. Ocular causes, you can work out echocornea or anterior chamber or cataract or lens or vitreous, like vitreous hemorrhage, toxoplasma or uveitis. Or optic neuritis, very simple optic neuritis, vision එක පේන්නේ blurred afferent pupillary defect එකක් තියෙයි or field loss එකක් තියෙයි. That's important. And then you get after optic nerve, or you can have it in the retina. Typical features you all know, blurred vision, flashes, floaters, and then pattak pain or totally gone. And then vessel occlusion, sudden painless visual loss, arterial, same way sudden visual loss, but not total gross visual loss එකක් නෙවෙයි vein occlusion. Pain but and when you see the fundus, easily you can see the differentiation. Arterial නම් ලේහෙම මොකුත් නැහැ, no bleeding, hemorrhages less, pale this, but it is vascular vein නම් lot of hemorrhages, cotton wool spot and things and like that. So then you have, or else මොකුත් නැහැ වගේ at a glance. See again, it may be in the macular problems, isn't it? Macular swollen, edematous, maybe even CSR. So that's macular problems. Or finally, non-ocular causes, brain, either stroke or hemorrhage, right? Visual field or mass or tumor. Slowly check the visual field, you will see the difference. Any questions? Okay. Thank you.